Hi friends, I am discussing OBS and Gynae previous year's questions for upcoming INI-CET exam. Now, first question is 16-year-old girl presents with primary amenorrhea. On examination, the breast development is normal, axillary hair is normal, and there is absent uterus and blind vagina present. Most likely diagnosis. Now let us see what are the options given to us. Number 1 is Mullerian agenesis. Number 2, androgen insensitivity syndrome, that is also called as testicular feminization syndrome, gonadal dysgenesis, and XXY syndrome. XXY syndrome, that is Klinefelter syndrome. So, Klinefelter syndrome, that is 47XXY, and in this case, when there is a Y chromosome, in this case, it is tall male with gynecomastia, hypogonadism, and infertility. So, in this case, testis is present. So, according to the question given to me, the Klinefelter syndrome does not fit into this category. Neither the gonadal dysgenesis fit into this category. Now, we have to differentiate between Mullerian agenesis and androgen insensitivity syndrome. Let us just write down the karyotype. In case of Mullerian agenesis, it is 46XX and the gonad is ovary. Since ovary is functioning normally, so secondary sexual characters, that means the breast development has to be normal and axillary pubic hair will be normal. For the development of the axillary pubic hair, it is androgen which is needed. Okay, so breast development is dependent upon estrogen, which is a hormone secreted by the ovary, and axillary pubic hair development is dependent upon androgen. So, according to the question given to us, androgen insensitivity syndrome does not fit into this category because the gonads are testis, and this is in the inguinal region, and it is secreting testosterone, but testosterone does not get converted into its active form dihydrotestosterone. So, the testosterone gets converted into estrogen, hence there is a breast development. But there is androgen insensitivity syndrome. So, in this case, axillary pubic hair will be absent and karyotype will be 46XY. So, this is again not androgen insensitivity syndrome. When the gonad is ovary, there is estrogen secretion and the ovarian function is normal. So, there will be development of the breast, feminine body figure. But since the uterus is absent, which is given to us in the question, answer to this question is Mullerian agenesis. In cases of Mullerian agenesis, the karyotype of the patient is 46XX. In this case, uterus is absent and lower vagina can be present and ovary is present. So, the breast development is normal and axillary pubic hair are normal. Okay, there can be blind vagina because lower vagina arises from urogenital sinus. Okay, treatment for this is, if the female is getting married or she is sexually active, okay, she is planning to start her sexual life, then vaginoplasty can be done. Okay, since uterine transplantation is not been possible. Now, let us move on to the next question. A pregnant female presented with amenorrhea, it might be 3 months or 4 months. The exact months of amenorrhea is not being provided to me in the question. There is spotting. On examination, pulse rate is 100 per minute, blood pressure is 110/70 millimeters of mercury, ultrasound was done and it showed. So this is an image-based question which has been asked in INI-CET exam, and similar question has been asked in the NEET PG as well as FMG exam. So image-based questions are very, very easy to answer as far as Obs and Gynae subject is concerned. So looking at the image, what do you see? The ultrasound image shows snowstorm appearance, and you know the snowstorm appearance is seen in a molar pregnancy. Snowstorm appearance is seen in the molar pregnancy. So let us see what are the options given to us. Ectopic pregnancy, abortion, molar pregnancy, and choriocarcinoma. If I look at the image and the type of history provided to me, it is Mullerian pregnancy. Okay, so H molar pregnancy, which is called as Mullerian pregnancy, it can be of two types, the complete mole or partial mole. And very important question which they ask is, how do you differentiate a complete mole from partial mole? Complete mole from partial mole, single and best answer is by karyotype. By karyotype, 90% cases. So here the karyotype is diploid, and in partial mole it is triploid. So 90% cases in complete mole it is 46XX, and 10% cases it is 46XY, whereas in partial mole it is 69XXX or 69XXY. Okay, so best way to differentiate a complete mole from partial mole is by karyotyping. And the abnormal chromosomes are paternal in origin. Abnormal chromosomes are paternal in origin. Next, 16-year-old girl presented with infrequent prolonged cycles. Image is given and ultrasound was done, showed bulky enlarged ovaries. FSH is 3.5, LH is 21. So FSH-LH ratio is altered. FSH to LH ratio is altered. TSH is given as 7.5. Which of the following is used to manage her? First of all, what is given in the question? In the question, there is a young female with menstrual disturbance, plus there is increased facial hair. So this is a feature of hirsutism. Menstrual disturbance, hirsutism in a young girl. So first diagnosis you are going to make is polycystic ovarian disease. And you know, polycystic ovarian disease, provided that other causes of hirsutism and menstrual disturbance you have ruled out. So very, very close differential diagnosis to this question is congenital adrenal hyperplasia, that is late onset. But in that case, there is prepubertal hirsutism which is seen. Other causes of hirsutism can be androgen producing ovarian tumor, or it can be adrenal gland tumor which is producing androgens. So most probably this is polycystic ovarian disease, provided other causes of hirsutism have been ruled out. In polycystic ovarian disease, you are supposed to remember the Rotterdam criteria, which includes hyperandrogenism, that is lab finding or clinical findings, then anovulation leading to menstrual disturbances like oligomenorrhea, etc., and ultrasound showing polycystic ovaries, which is necklace pattern of ovaries. Now, since from the question it is clear that it is polycystic ovarian disease or polycystic ovarian syndrome, in that case, first step in management, before we read the options, what is in your mind, how you are going to manage, is always a lifestyle modification. Similar question has already been asked in previous AIIMS PG entrance examination as well. So first step is always lifestyle modification, that is exercise and eating a very, very healthy, taking a very, very healthy diet, doing brisk walking. This will reduce the androgen levels, And when the androgen levels in the body are reduced, hirsutism will get corrected, and decrease androgen levels, the ovarian function will automatically start and the female can start ovulating. Next step is always the drugs, and the best drug to manage the hirsutism is combined oral contraceptive pills, which is called as low dose contraceptive pills. So what are the options given to us? Lifestyle modification and weight reduction. Yes, this is the first step. Number 2 is the oral contraceptive pills. Yes, that is also used. Number 3, anti-androgens like cyproterone acetate, finasteride, etc. These are anti-androgen drugs, but ovarian drilling in a young female is not recommended. So the correct option according to me is A, B, C is correct. Lifestyle modification, weight reduction, oral contraceptive pills and anti-androgen drugs, but laparoscopic ovarian drilling is not recommended in this question. Now, next question, semen analysis shows azoospermia. Which of the following can differentiate testicular failure from obstructive azoospermia? Since they have specifically asked about testicular failure and obstructive azoospermia, so azoospermia means absence of sperms. So options given to me are FNAC testis, FSH levels, testosterone levels and karyotype. Karyotyping usually is not our first step in diagnosis or the management part. Usually we get the hormonal levels done, and usually the hormonal levels which we do is FSH and testosterone levels, because we want to differentiate the level of pituitary, the level of testis and the level of vas deferens. Okay, so it can be pituitary cause of azoospermia, it can be testicular azoospermia, that is called as testicular failure, or it is post testicular azoospermia. So in that case we get FSH and testosterone levels done. But since they have not asked the pre-testicular or post-testicular causes, they just want to differentiate gonadal failure from obstructive azoospermia. So the best answer according to me will be FNAC testis. Although nowadays, like biopsy or FNAC is not very first line investigation as we do. We can get a correct answer depending upon the hormonal analysis as well. But according to this question, my answer will be FNAC testis. Now, this is testis, this is epididymis. The spermatogenesis takes place in the testis, and the sperm maturation and motility occurs in epididymis. Then the sperms enter into the vas deferens, and the seminal vesicle, it secretes the seminal vesicular fluid, and from there the sperms enter, and from the ejaculatory duct, it is during ejaculation it is being taken out from the male genital tract. So answer to this question is FNAC testis. Now, next question, a female presented in the OPD with vaginal discharge. Identify the causative agent given in this image. So, the options given to me are trichomoniasis, Candida, Gardnerella or Dodderline bacillus. So, according to this image, it appears to me as clue cells, okay, clue cells where the bacteria gets adherent to the epithelial cells, which gives a appearance of clue cells, and clue cells are seen in bacterial vaginosis. In case of bacterial vaginosis, the Dodderline bacillus or lactobacilli are replaced by Gardnerella. They are being replaced by Gardnerella. So answer to this question is Gardnerella. Clue cells are significant finding in bacterial vaginosis, which is caused by Gardnerella vaginalis. Now, you should remember the Amsel's criteria as well in bacterial vaginosis. Amsel's criteria include pH is shifted towards alkaline, then there are clue cells present, there is fishy or musty odor, vaginal discharge, then whiff test is positive, which is also called as amine test. In that case, you take the sample, the vaginal discharge on the slide and put QH. What you find is a fishy smell. So that is what is an Amsel's criteria. Remember, bacterial vaginosis is not STD. And number 2, there is no itching. And there is a dirty vaginal discharge and there is a fishy smell. Now, drug of choice to treat bacterial vaginosis is metronidazole. So this you should remember for bacterial vaginosis, which is always an expected question in INI-CET pattern of exams. Next, 30-year-old female presents with itching, green color vaginal discharge. You know, green color itching discharge is suggestive of trichomoniasis. Okay, so when you are reading any question in Obs and Gynae subject, most of the time there is a hint in the question. So you make an image. Now, itchy, that means either it is trichomoniasis or it is candidiasis. Okay, it cannot be bacterial vaginosis. Okay, because itching is absent in bacterial vaginosis. Number 2, what is the color of the discharge? It is a green color vaginal discharge, which is creamy, thin, profuse, creamy, green color vaginal discharge, which is seen in trichomoniasis, which is caused by protozoa. Then, strawberry cervix or strawberry vagina, it is clear cut. Your diagnosis from the history is trichomoniasis, which is caused by a protozoa. It is STD, and there is pruritus vulvae, which is the most common symptom. So, what is a drug of choice against trichomoniasis is metronidazole. So, answer to this question is metronidazole. Next question. In India, emergency contraceptive contains. Now, which is the most commonly used emergency contraceptive? Most commonly used emergency contraceptive in India is LNG pill, levonorgestrel pill, that is 1.5 milligram single dose to be given within 72 hours of unprotected coitus. Now, which is the best emergency contraception? That is IUCD, that is to be given within 5 days of unprotected coitus. And which is the type of IUCD that is recommended is copper T. So, these two questions are very, very important. Again and again, they are asking a question from emergency contraception. Now, in India, emergency contraceptive used contains LNG, that is levonorgestrel pill, 1.5 milligram single dose. Okay. Although others are also applicable as an emergency contraception, but one answer they have asked, so it is LNG pill. Now, if you talk about the postcoital contraception, which means the emergency contraception, it is hormonal, that is to be given within 72 hours of unprotected coitus, or it is within 5 days of unprotected coitus. Among the IUCD, it is copper T. Mirena or hormone-releasing IUCD is not an emergency contraceptive. Now, among the hormonal, it is LNG pill, which is best and preferred. Number 2 is oral contraceptive pills, which is to be given 4 tablets after a gap of 12 hours, 4 tablets. It can be any OCPs, Mala-D, Malayan, Novilon, Familon, etc. Number 3 is RU486, that is mifepristone. Now, there is one more emergency contraception, that is ulipristal, which is 30 milligram to be given within 5 days of unprotected coitus. It is progesterone receptor modulator. ठीक है, progesterone receptor modulator. Next, match the tumor markers with their respective tumors. Now, let us read this question. Dysgerminoma, which is a germ cell tumor of the ovary. What are the tumor markers being produced by dysgerminoma? So, we know it is LDH and alkaline phosphatase. So, in the options, LDH is already written. Okay. Number 2, yolk sac tumor, which is also called as endodermal sinus tumor. The tumor markers are alpha-fetoproteins and antitrypsin. So, alpha-fetoproteins is given. Now, in this question, which was asked in INI-CET, there were the options given in the block. Okay. Options given in the block, and here also the numbering was given. Okay. So, we can just do it as, like match the following format. Choriocarcinoma, the tumor marker is beta HCG. Epithelial ovarian tumors, it is CA125, and granulosa cell tumor, it is inhibin. So, I hope it is very, very clear-cut, straightforward question. Next, according to WHO, clear cell carcinoma of the ovary belongs to which category of ovarian tumors? Clear cell carcinoma of the ovary belongs to epithelial ovarian tumors. So, according to the WHO, okay, there are 4 categories of ovarian tumors. Number 1 is epithelial ovarian tumors. Number 2 is germ cell tumors of the ovary. Number 3 is the sex cord tumors, and number 4 is the metastatic, which is Krukenberg. So, epithelial ovarian tumors, clear cell carcinoma is epithelial ovarian tumors. Next, according to the criteria that International Association of Diabetes in Pregnancy Study Group, the cutoff value for fasting blood sugar to diagnose diabetes in women in pregnancy with a one-step method, what is your answer? It is 90 milligram per deciliter, 92 milligram per deciliter, 95 milligram per deciliter, or 101 milligram per deciliter. So, the correct answer is 92 milligram per deciliter. So, 75 grams of glucose is given. There is fasting sample, 1 hour and 2 hour. So, it is 92 milligram per deciliter. Then it is 180 milligram per deciliter and 153 milligram per deciliter. So, this is what is the correct answer. Since they have just asked the fasting value, so it is 92. You should remember the DIPSI criteria as well as Diabetes in Pregnancy Society of India. That is, you gave 75 grams of glucose and you can take the blood sample after 2 hours. The cutoff value is less than 140 milligram per deciliter. This is used for universal screening of diabetes in pregnancy in India. So, many times they ask the cutoff value. This is very, very important for questions, and this is according to the DIPSI criteria. Which of the following inhibits lactation during pregnancy in spite of high levels of prolactin? Now, during pregnancy, the prolactin hormone is responsible for lactogenesis. Okay. Prolactin is responsible for lactogenesis, but this milk secretion is not released until the child is born, and suckling reflex is an important reflex for the release of milk, because while the baby starts sucking, there is a reflex that goes to the maternal pituitary. Which part of the pituitary? Posterior pituitary. From that, oxytocin is released, and oxytocin helps in 2 ways. Number 1, it acts on the breast. It causes the contraction of the breast tissue and the milk is released and baby can start feeding. Number 2, the oxytocin which is released from the maternal Pituitary, which part? Posterior pituitary, and that acts on the uterus and cause contraction of the uterus, so postpartum hemorrhage can be prevented. That is why it is always advised to put the baby on breastfeed as early as possible. So during pregnancy, the levels of estrogen and progesterone are high. Progesterone is the hormone that maintains pregnancy. So these hormones have an inhibitory effect to the milk secretion. So if I have to mark one answer, I will mark high levels of estrogen is responsible that inhibits the milk release in spite of the high levels of prolactin. Next question. Dose of dexamethasone given to a pregnant lady in case of preterm pregnancy to cause fetal lung maturity. So what are the options given to me? There are two types of steroids which can be given, dexamethasone or betamethasone. Betamethasone may be better option, and the dosage is comparatively, less. Here there are 4 doses that is needed. When you talk about betamethasone, there are 2 doses that is sufficient enough to cause fetal lung maturity in cases of you are expecting a preterm delivery. But availability is a problem. So dexamethasone is easily available. So among the options given to me, 6 milligram 24 hours apart 4 doses, 6 milligram 12 hours apart 4 doses, 12 milligrams 24 hours apart into 4 doses, or 12 milligrams 24 hours apart into 4 doses. So correct answer is 6 milligram 12 hours apart into 4 dosage. Next, identify the pelvic diaphragm in the given image. So let us see, this is the image which is showing the supports of the uterus. So there are 4 blocks which has been marked A, B, C and D. Now this is the uterus, this is the bladder and this is the vagina. And these are the muscular supports which have been shown in this image, and this is the pelvic bone which has been given. Now you can see in A, this is endopelvic fascia. This C part is urogenital diaphragm. In the exam, the markings is not given. Okay, because I have taken this image from the net. Now, this is the way they have asked the question. So, they have asked about the pelvic diaphragm. Pelvic diaphragm, that is levator ani muscle. Levator ani muscle and its parts. So we create the questions according to what the students who have written the exam they provide to us. So we select the image from the net itself, and what I can understand from this is they have asked the pelvic diaphragm and they are asking about this particular muscle. Okay, so this particular muscle according to me is the pelvic diaphragm. So correct answer is B. Now, supports of the uterus are true muscular supports and true ligamentary supports. True muscular supports includes the pelvic diaphragm, urogenital diaphragm and the perineal body. And true ligamentary supports includes the McEnroe ligament, which is cardinal ligament, which is holding the cervix from both the sides to the lateral pelvic wall. This is the strongest ligament and this is the most important support to the uterus and the cervix. Next is pubocervical ligament and third is uterosacral ligament. Among the uterosacral ligament, you should remember this is a very, very important ligament to prevent retroversion of uterus. This is important ligament to prevent the retroversion of uterus. Now, next question, which of the following is correct according to WHO guidelines for managing the second stage of labor? Second stage of labor, friends, it means the delivery of baby. The cervix has become fully dilated, that means 10 centimeters. Descent of the fetal head or the fetal presenting part has already taken place. Now, delivery of the baby has to be conducted. Now, according to the WHO guidelines, INI-CET, always there are 1 or 2 questions on the latest guidelines, like they have asked on the HPV vaccination, the latest guidelines, then they have asked latest guidelines of the normal labor or the delivery process. Now, this is one of that question. Now, what are the options given to me? Delivery preferably in lithotomy position. This you know is a correct answer. Then number 2, routine episiotomy. Number 3, manual support to the perineum to maintain the head in deflex state. Number 4, warm compress to perineum to decrease the pain. So manual support to the perineum to maintain the head in deflex state, that is a modified Ridgen maneuver has to be done, and warm compress to the perineum, that is also been done. So what is the wrong answer in this question? So answer in this question is B. Okay, many of the students might not agree, but this is correct. Routine episiotomy is not recommended. The undergraduate book that you read, Datta, that is also in the latest edition, it is clearly written that there is a controversial point, but the correct answer is routine episiotomy is not recommended. Episiotomy is reserved for those cases where you are conducting a delivery, that is instrumental delivery, or you are doing the breech vaginal delivery, or you are conducting a twins vaginal delivery, or those females you are conducting the delivery where there is a very, very tight and rigid perineum. So you want to avoid any tear. So the episiotomy is recommended, but not routinely recommended in all the deliveries you are conducting. Next question, 60-year-old female presents with vaginal bleeding. She is diabetic, hypertensive. Best investigation for her. So there are already hints in these two-lined question. Number 1, 60 years, which is a perimenopausal. Okay. Number 2 hint, she is diabetic. Number 3, she is hypertensive. So let us just write down perimenopausal age group. Number 2, diabetes. Number 3, hypertensive. And number 4, or important part, she has presented with vaginal bleeding. Now, what does this signify? It is not, like 100% she will have cancer, but it is signifying. The lady is 60 years, that is a perimenopausal. She presented with vaginal bleeding, which is called as postmenopausal bleeding in this case. She is diabetic, she is hypertensive. And what will be the best investigation in this case? The provisional diagnosis, according to me, may be endometrial cancer. I am not saying that 100% it is endometrial cancer, but most probability, according to the history provided to me, is endometrial cancer, and investigation for endometrial cancer will be endometrial sampling. Endometrial sampling. I would have thought of cancer cervix and would have thought of pap smear. Okay, but in that case, number 1, 60 years will not be there. It might be a reproductive age group. Number 2, even if 60 years is given, it might be irregular bleeding or postcoital bleeding. That will be the hint in the question. Number 3, there will not be any history of diabetes and hypertension, because they have specifically given diabetes and hypertension just to give you a clue that it is endometrial cancer. And investigation here, it will be endometrial sampling using a pipple. So in this case, a pipple can be used, or there can be a Carman's cannula which can be used, and you can take the sample and put it in the formalin to send it for histopathological examination. So according to me, it will be endometrial sampling. Now next question is, HCG is structurally and functionally similar to FSH, LH, TSH and oxytocin. We have already studied that HCG has got 2 units. HCG has got 2 units, the alpha subunit and beta subunit. Alpha unit is non-specific and beta unit is specific. Beta unit we detect in urine or maternal blood to diagnose for pregnancy. It is also used when we are dealing with a case of ectopic pregnancy, we have given the medical treatment, or in cases of diagnosis of ectopic pregnancy, beta unit is also detected in the blood. Then it is also for H molar pregnancy, as well as it is a tumor marker for cases of choriocarcinoma. It's an important tool for follow-up as well. And beta HCG injections are also given in cases of infertility to trigger the ovulation. Okay? To trigger the ovulation. Now in this question, they have asked about the alpha subunit. If I have to mark one answer, then alpha subunit structurally and functionally similar to that of LH. Okay. Otherwise, it is similar to FSH, TSH and LH. But when they have asked structurally and functionally together, then my answer will be LH. Now, all of the following are markers of quadruple test for aneuploidy except. Now, in quadruple test is done, timing for quadruple test is 16 to 18 weeks. Maternal blood is taken and we detect alpha fetoproteins, beta HCG, estriol and inhibin A. Alpha fetoproteins are decreased, beta HCG rises, estriol decreases, inhibin A rises. This is the finding for trisomy 21. So, which is the fourth marker in quadruple test? Now, triple test we do till here. Alpha fetoproteins, beta HCG and estriol. Now, if you compare the result, naturally the quadruple test has replaced the triple test. So, alpha fetoproteins is done, HCG is done, estriol is done. Inhibin B is not the answer. So, the correct answer, the fourth marker is inhibin A, not inhibin B. Next, the instrument shown in the image is used for doing which of the following procedure? Is it colposcopy? Is it pap smear? Is it cervical biopsy? Or is it endometrial aspiration? Now, let us just identify this image. I have already mentioned that image-based questions are very, very simple to answer as far as OBS and Gynae subject is concerned. Now, this is Ayer's spatula. This is a cyto brush, and this brush is used to take liquid based cytology, that is liquid paps. So these two are for conventional pap smear, and this is for liquid based cytology. So the answer to this question is pap smear. Now, pap smear for many years has been used as a primary screening test for dysplasia or cancer cervix. Now, WHO recommendation is, if there is a facility that is resource-rich countries, now the primary screening test is HPV DNA testing. And what is the age group when you should start the HPV DNA testing? The correct answer is by 30 years of age. Okay. Why it is not done early? Because the 20 to 30 years age group, the HPV infection occurs in sexually active females, and by 30 years, like the body defense mechanism clears out this HPV. If it persists, then testing is recommended after 30 years of age. Now, why pap smear is being replaced in resource-rich countries by HPV DNA testing, because after a pap smear, which is a screening test, a confirmatory test, that is a colposcopy, is needed. For that, there has to be a specialized, setting to perform the colposcopy, and a trained gynecologist is needed to perform the colposcopy. Okay, whereas there are resource limited countries, maybe VIA, that is visual inspection under acetic acid, is being used as a primary screening test, and it is cost effective because mass screening can be done. Now, next question, which of the following is correct order in which a pap smear is to be taken? Now, placing the vaginal wall retractor. Number 2, fix the slide. Number 3, scrape the ectocervix. And number 4, prepare the smear. So, first of all, you put in a Cusco speculum or a Sim speculum with an anterior vaginal wall retractor. So, the sequence will be A first. Then, number 2, you should take the scraping with an Ayers spatula. And number 2, with a cyto brush. So we are doing screening. If you are using a conventional paps, in that case, first sample is to be taken from the lip of the cervix, and we rotated this Ayers spatula 380 degrees. This is 360 degrees. This is to screen for squamous cell carcinoma. And another sample on a slide, we take it from endocervix, that is to screen for adenocarcinoma. Then fixative we use is 95% ethanol plus ether. Now, if we are doing a liquid-based cytology, then there is a plastic spatula and there is a bottle which contains the liquid. This one sample is taken and this is put in this bottle. So, second is scrape the ectocervix, and third part is prepare the smear, and fourth part is fix the slide. So, the correct sequence is A, C, D and B. Next, which of the following represent the symptoms of endometriosis? Endometriosis means the presence of endometrial glands and stroma outside the uterine cavity. Okay? The presence of endometrial glands and stroma outside the uterine cavity, and the most common site being the ovary, where it is present as chocolate cyst ovary. Other sites can be rectovaginal septum, pouch of Douglas, uterosacral ligament, urinary bladder, appendix, sigmoid colon, etc. Okay, so the rare site is the CNS. Now, what is the most common symptom? Okay, so the endometriosis, the most common symptom is always pain. Pain in the form of congestive dysmenorrhea. So this is the most common presenting symptom. Other symptoms include, another presentation can be infertility. Third presentation can be dyspareunia. Then there can be menorrhagia or chronic pelvic pain. Okay, now let us see what are the options given to us. Menstrual disturbance, dysmenorrhea, infertility, vaginal discharge. First of all, vaginal discharge is never the presentation of endometriosis. Okay, menstrual disturbance is the presentation, but that may not be the most common presentation. So, most common presentation of endometriosis are two. Number 1 is dysmenorrhea. Number 2 is infertility. Another presentation of endometriosis can be adnexal masses. Like this is the uterus and there are big chocolate cyst of ovaries. So it can be an presentation like adnexal masses. Among the classical triad is pain, infertility and dyspareunia is a triad. Okay, so let us see what are the options given to us. A and B, no. A and C, no. A and D, no. So the correct answer is B and C, that is dysmenorrhea and infertility. And what is the gold standard investigation for endometriosis? Always remember, laparoscopy is the gold standard investigation. Number 1, it will confirm your diagnosis, and number 2, you can simultaneously treat your patient. Okay, you can simultaneously treat your patient. Now, next question, cutoff value for sperm morphology to call it normal according to the WHO cutoff criteria. So, answer to this question is 4%. Now, let me just write down WHO cutoff limit in semen analysis. ठीक है, WHO cutoff limit in semen analysis is amount, count, motility and morphology. ठीक है, amount cutoff is 1.5 ml, count is 15 million per ml, motility is 40% and progressive motility is 32%, morphology is 4%. So in this question, they have asked about the morphology. So this is the answer. Fine. Now, what is the most important fertility indicator in semen analysis? Most important fertility indicator in semen analysis is sperm morphology should be normal. After that, if that is not written, motility will be the correct answer. But first answer to mark is morphology of the sperms should be normal. Now, next, analyze the hormonal profile of a 25-year-old woman presented with amenorrhea. Now, what can be the hormonal findings in PCOS, that is polycystic ovarian syndrome? This is very, very important question of INI-CET exam. Asherman syndrome, premature ovarian failure, Sheehan syndrome. Let me again mention it once more that all that questions in all the parts I am discussing, this is all INI-CET exam questions which has been asked in last 3 years, including this year 2023 May exam. So all that questions I have collected and I am discussing. Now, PCOS, polycystic ovarian disease, Asherman syndrome. Let's start with Asherman syndrome. Asherman syndrome is that FSH, LH, estradiol, all these hormonal levels is normal because pituitary is normal, ovary is normal, uterus, there is a defect that there is formation of adhesions or synechiae. So that is why there is secondary amenorrhea and cause is vigorous curettage during MTP or DNC. So Asherman syndrome, always remember FSH, LH and estradiol levels should be normal. So here the answer is 2. Now we talk about the premature ovarian failure, that there is depletion of the ovarian follicles. Okay, so FSH, LH levels will be elevated and estradiol levels will be down. So FSH is elevated, LH is elevated and estradiol is down. So what is that answer? Answer is A, that is 1. Now next. Next is Sheehan syndrome, where there is postpartum pituitary necrosis. So FSH, LH, estradiol all will be down. FSH down, LH down, estradiol is also down. So the answer is 3. Now we talk about PCOS. In PCOS, polycystic ovarian syndrome, FSH will be normal, sometimes it is low, LH is elevated, and estradiol is normal. So the answer is 4. Okay. So this is the way you should be able to solve such question when there is a match the following. So in this, they must have given the options like 1, 2, 3 and 4, and which is the correct answer that you should know. So this way you will be able to solve it correctly. Next, 35-year-old second gravida para 1 L1 with previous normal delivery now comes in third trimester for ANC checkup. Blood pressure is 150/110 and proteinuria is plus. All are imminent symptoms of eclampsia except. So this, according to the question given to me, is case of severe pre-eclampsia. Okay. And they have asked what are the symptoms of impending eclampsia. So we know it is always headache, epigastric pain, blurring of vision, or there may be decreased urine output. Nowadays, there is a criteria for end organ damage where there is cerebral and visual symptoms. There is elevated liver enzymes, LDH is elevated. There is, like platelet count is reduced, and there is serum creatinine which is raised. Now, if you talk about the symptoms, then headache is a symptom, nausea, vomiting, epigastric pain is a symptom, but pedal edema, which is persistent, is not included in the criteria that decides the imminent symptoms of impending eclampsia. So, answer to this question is pedal edema. Now, next question, 35-year-old para 2 L2 with previous to normal deliveries presents with pain abdomen which is dull aching, non-radiating. Her LMP was 20 days back. A clear left ovarian cyst 5 centimeters was detected on ultrasound. What is the best management for her? Let us just review the question once more. She is a para 2 L2. She had 2 normal vaginal deliveries. She had her LMP 20 days back, and there is an incidental finding of left ovarian cyst that is 5 centimeters. Okay. Now, what are the options given to me? Are you going to do CA-125 in her? Follow up after 2 to 3 months, do a diagnostic laparoscopy or do a CT scan? Well, she is a female. She has come for a regular checkup, and she had 2 normal deliveries. Then there is just an incidental finding of ovarian cyst. Most likely appears to me it is a functional cyst, and functional cyst needs observation. And if you have to repeat her ultrasound, if she has any pain or if the size of the cyst is increasing, you can do just a routine checkup after 3 months, or you can just get an ultrasound done. Okay. So according to me, just a follow-up is needed. Since in this age group, what is the history given to me? I am not in favor of getting a CA-125 done. She is not a premenopausal or postmenopausal female. Number 2, why should I go for a diagnostic laparoscopy? Because I am just suspecting a functional cyst and she is asymptomatic. So it is not indicated. She is not any case of any cancer. Nothing finding is suggestive of such that. So I am not going to recommend any CT scan. Just a routine follow-up after 2 to 3 months to check for any symptoms, to check for any increase in the size of the cyst, or cyst may disappear spontaneously, or if there is any pain, I will ask her and I will just get an ultrasound done if needed. Now, next question, which of the following is not a component of active management of third stage of labor? All of you know that WHO guidelines for active management of third stage of labor, many times this question is being asked, whether it was an AIMS PG entrance exam, INI-CET exam, or a NEET PG exam or an FMG exam. This is a very, very favorite question for active management of third stage of labor. And we know in the active management of third stage of labor, we have to give injection oxytocin intramuscular bolus after the delivery of anterior shoulder or after the delivery of the baby. Then we have to deliver the placenta by controlled cord traction method. Then we have to do a delayed cord clamping. These are the components of active management of third stage of labor. So let us see what are given to us in the question. The main aim for active management of third stage of labor is to prevent postpartum hemorrhage, which is the most common preventable cause of maternal mortality in India. Okay, so controlled cord traction method is correct. Early cord clamping is not done. Uterotonics, that is in the form of oxytocin, is given after the delivery of the placenta, and uterine massage is also not included. So this is multiple answer question in INI-CET pattern because it is a combined exam for AIMS PG entrance, PGI Chandigarh entrance exam, where there are more than one option correct in the questions. Then it is JIPMER PG and it is NIMHANS. Okay, so here the answer according to me are A and C. Now in this image it is shown as controlled cord traction method to deliver the placenta. Uterine massage is a part of atonic PPH management. It is a part of atonic postpartum hemorrhage management. Fine. Next question. Which of the following karyotype matches the profile given? Okay. Now, whenever any karyotype is being given, always try to read the image like the pair of chromosomes. There are 22 pair of chromosomes and 1 pair of sex chromosome. So you can see all the 22 pairs of chromosomes are perfect. One X is absent, so the karyotype is 45XO, and this karyotype is for Turner syndrome. So first, always in Obs and Gynae, try to read the question options and the image given, and then later on you can read the options once more. So it is short stature, mental retardation. Mental retardation is not there in Turner syndrome. IQ level is absolutely normal. Tall gynecomastia, that is a feature of Klinefelter syndrome. Again, the karyotype does not match with Klinefelter syndrome. Short stature, web neck, and number 4 is hypotonia and flat occiput. That is again not the answer. So short stature, congenital webbing of neck, cubital valgus deformity, hypoplasia of breast. This is the what is a Turner syndrome. Now, what is a type of congenital heart disease in Turner syndrome is bicuspid aortic valve, as well as mental retardation. IQ level is absolutely normal. If bicuspid aortic valve is not given, then your next answer is coarctation of aorta. Next, 28-year-old female presented with oligomenorrhea, hirsutism, wants to conceive. So it is oligomenorrhea, hirsutism and infertility. 3 things are mentioned. She has been diagnosed with PCOS. Which of the following is not helpful in the management of this case? So this is a case of polycystic ovarian disease, and she is already a married female and she is facing infertility problem. Okay, but most treatable form of infertility is always polycystic ovarian disease, and you know the treatment is ovulation induction. Nowadays, drug of choice for ovulation induction in PCOD is letrozole compared to clomiphene citrate, but clomiphene citrate can also be given. Now, let us read what all are the options given to us. Metformin, yes, metformin is given. That will decrease the insulin resistance and regularize the cycles. So, automatically the female starts ovulating. So, the metformin is given in PCOS patient, and even if the female conceives on metformin, it does not cause any teratogenic effect. Clomiphene citrate is the one which is given as an ovulation induction agent. Now, combined OCPs, again, will not solve the purpose because this patient wants to conceive. Now, which of the following is not helpful? Tamoxifen is not going to be helpful. Even if it is a case of infertility, even combined OCPs will provide the contraception. Okay. If it is, like what is not helpful, okay, will be the tamoxifen. But if they are not just concerned about the infertility, they just want the drug management. So combined OCPs also corrects the hirsutism and the menstrual irregularities. If conception word is not written, then your answer goes for C. Tamoxifen has got no role in PCOS cases. Now, identify the fetal anomaly shown in the image. You can clearly see this is a frog's eye sign on ultrasound, and frog eye sign is anencephaly. Which of the following investigations are helpful in diagnosing the unicornuate uterus except? Okay, so the options given to me are HSG, that is hysterosalpingography, laparoscopy, X-ray, and fluoroscopy. Okay, so these two are not recommended for diagnosing a unicornuate uterine anomaly. So HSG and laparoscopy are the correct answers. Now, one more thing, I have added up this slide. You have to remember the type of uterine anomalies according to class. So class 1 is Mullerian agenesis, where uterus is absent. Class 2 is unicornuate uterus. So presently the question is class 2, and such question has already been asked in one of the exam. Class 3 is uterus diadelphus. Class 4 is bicornuate uterus. Class 5 is septate uterus. Septate uterus is most common Mullerian duct anomaly. Most common Mullerian duct anomaly. Class 6 is arcuate uterus, and class 7 is DES related. If you ask me which has got a best reproductive outcome, so the answer is arcuate uterus. Now, this is an image of HSG showing a unicornuate uterus, where one uterus has developed from only one cornu and another cornu is not shown in this image. The horn is not connected to the rest of the uterine cavity or rudimentary horn if functional. The blood can get collected and this can lead to unilateral dysmenorrhea. Okay, on one side there is chances of dysmenorrhea, and because of retrograde menstruation, the chances of endometriosis is also increased in this type of anomaly. Now, if the horn is connected, rudimentary horn is connected to the rest of the uterine cavity, then there may be a chance of ectopic pregnancy in this rudimentary horn. So these two things you should remember. And as far as the reproductive outcome is concerned, it is comparatively poor reproductive outcome in cases of unicornuate uterus. Now, the next question, following are the causes for amenorrhea. Match the causes with the karyotype. MRKH syndrome, that is Mayer-Rokitansky-Kuster-Hauser syndrome, which is a type of Mullerian agenesis. So Mullerian agenesis, the karyotype is always 46XX because it is normal functioning ovaries. Okay. Turner syndrome, it is ovarian dysgenesis. So karyotype is 45XO. There is ovarian dysgenesis and there is streak gonads, and this is most common cause for primary amenorrhea. Androgen insensitivity syndrome, it is 46XY karyotype, where there is tall smart looking females, but breast development is present, axillary pubic hair are absent. Okay, so there is gonads which is undescended testis in the inguinal region. And Swyer syndrome, it is again the flat females with no breast development, and it is external genitalia as female and there is undescended testis. So there is streak gonads. Okay, so this is what is the correct matching for the karyotyping. Next question is marker for ovarian reserve. What do you understand by ovarian reserve? Ovarian reserve means number of resting follicles in ovaries. With age, it decreases. Now, what are the options given to us? Let us see. Luteal phase FSH, luteal phase estradiol, anti-Mullerian hormone, or follicular phase estradiol. Now, let us go one by one. Now, ovarian reserve means number of resting follicles in the ovary. Number one, what are the tests which are done? This is according to the Novak's gynecology textbook. Okay. Now, it is FSH levels which is done on day 3 and day 10. Number 2, clomiphene challenge test. Clomiphene is given from day 2 to day 7. Then there is estradiol levels, there is inhibin B levels, there is anti-Mullerian hormone, and there is antral follicle count by transvaginal scan. These are the tests which are recommended to check for ovarian reserve. Now they have asked which is the best marker. Okay, which is the best marker for ovarian reserve. So according to the points which I have written, the best marker or best test for ovarian reserve is anti-Mullerian hormone. Now anti-Mullerian hormone in the females is secreted by granulosa cells of the ovary, and in the males it is been secreted by Sertoli cells, and it inhibits the development of the Mullerian duct in the boys. Now it is secreted by granulosa cells in the ovary at the time of puberty. That means after the puberty is been attained. Okay, anti-Mullerian hormone is not affected by any feedback inhibition. Okay, so it has not been affected by any feedback inhibition. If its value comes out to be less than 1 nanogram per ml, this is consistent with poor ovarian reserve. So it can be done any time of the menstrual cycle. Like for FSH, we do it day 3 value, but AMH can be done anytime. So this is the best marker for ovarian reserve. Suppose if there is a diminished ovarian reserve, what is the treatment for infertility in cases of diminished ovarian reserve? So answer to this question is doing IVF using donor oocytes. Doing IVF using donor oocytes. So these things you should remember, because such questions are very commonly asked in INI-CET pattern of exams. Now next question is match the following. Such question has already been asked in INI-CET, and this question has already been asked in NEET PG exam as well. So let us see what are the options given to me. Kit 1, Kit 2, Kit 3 and Kit 6, and on the right side it is written as PID, that is pelvic inflammatory disease, urethral discharge, vaginal discharge and non-herpetic genital ulcer. Okay, so let us just match this. Kit 1. Kit 1 is for cervicitis, and it is gray color kit. Kit number 2 is for vaginitis, that is green color kit. Kit 3 is for non-herpetic genital ulcer, and kit 6 is for PID. So let us see. The urethral or cervical discharge is kit 1, that is gray color. Vaginal discharge kit number 2, which is green, that contains sacnidazole and fluconazole. Sacnidazole is going to be effective against the trichomoniasis and bacterial vaginosis, and fluconazole is for candidiasis. These are the 3 causative agents for the vaginitis, whereas kit number 1 contains azithromycin and cefixime. The azithromycin is against chlamydia and cefixime is against the gonorrhea infection. Kit number 3 is non-herpetic genital ulcer, that is white kit, which contains penicillin and azithromycin. Then if the patient is allergic to penicillin, then kit number 4, that is blue color kit, is given. Then herpetic ulcer is kit number 5, red color kit, and that is containing acyclovir. Then lower abdominal pain, that is PID, that is kit number 6, which is yellow color, and inguinal bubosis kit number 7, that contains doxycycline and azithromycin, that is a black color kit. So in this question, the match the following is: kit number 1 is urethral discharge, kit number 2 is vaginal discharge, kit number 3 is non-herpetic genital ulcer. Non-herpetic genital ulcer, it is white color kit. Then PID, that is yellow color kit. Okay. Next, the complication which is specific to monochorionic twins. Monochorionic twins, that means there are just the like single chorion. Okay, so this is a type of monozygotic twins, and monozygotic twins are sharing a single placenta. Monochorionic means sharing a single placenta. So that means there is one placenta between the two babies, so they can have communicating placental channels. So there is a complication that can occur, that is a twin-twin transfusion syndrome, where perinatal mortality is very high. The criteria is twins are always of the same sex, they have a single placenta, they are always monozygotic twins, there is discrepancy in fetal weight to 25%. So this is ultrasound diagnosis of monozygotic twins, which is monochorionic, and there is a risk for twin-twin transfusion syndrome. Next, all of these investigations are cost-effective screening tests done routinely in pregnancy, except, okay, that is, like bacteriuria, that is urine routine microscopic examination, echo for cardiac disease, screening for gestational diabetes, and VDRL for syphilis. So, routinely screening for gestational diabetes is done, that is by either glucose challenge test or by the DIPSI criteria. This is a universal screening cost-effective method to be screening for diabetes in all pregnant ladies. VDRL is national recommended guidelines for syphilis. Then urine examination is also being done, but echo is not a cost-effective and it is not routinely done in the pregnant ladies. It is a very, very specific investigation, and it is costly in compared to the other 3 investigations given in the list. Now, which is incorrect regarding the magnesium sulfate in pre-eclampsia or eclampsia patients? It has an anticonvulsant effect on cerebral cortex and simultaneously lowers the blood pressure. Always remember that, magnesium sulfate is not antihypertensive drug. So magnesium sulfate is not an antihypertensive drug. Now let us read what are the other options. Magnesium sulfate quietens the uterine activity. This action is dose dependent. Maintains the dose is given 24, maintenance dose is given 24 hours after delivery or 24 hours after the last convulsions. This is also correct. Now it quietens the uterine activity. That is also correct. So magnesium sulfate is also a tocolytic agent, although we are not commonly using magnesium sulfate. Commonly used tocolytic agent is nifedipine or beta adrenergic drugs. Now, number 4, magnesium sulfate is entirely excreted by the kidneys. That is very important. That is why measuring the urine output is very, very important. If the urine output is less, then magnesium sulfate should be stopped and it is to be replaced by another anticonvulsant, which is phenytoin in cases of severe preeclampsia or eclampsia patients. So this is also correct. So wrong option is it is not an antihypertensive drug. Now, which is not included in the diagnosis of preterm labor? Cervical dilatation of more than 1 centimeter, cervical effacement of more than 80%, 4 contractions in 20 minutes or 8 contractions in 60 minutes. Cervix is always central or posterior. This is a previous criteria based questions. Now it has been changed according to the latest edition, but cervix is central or posterior is never included for the diagnosis or criteria for preterm labor. So answer to this question is D. Next, which is incorrect regarding the pathogenesis of preeclampsia? Angiogenic factors play an important role in preeclamptic women. There is an increase in SFLT1 and decrease in PIGF. This is correct. Prostaglandins play an important role. There is decrease in thromboxane A2 and increase in prostacyclin thromboxane ratio in preeclampsia. The endothelial cell dysfunction, this is also correct. And there is reduced nitric oxide. Nitric oxide has got a vasodilator effect. That is why there is vasoconstriction, because nitric oxide levels are reduced. Vasoconstriction leads to ischemia, necrosis, hemorrhage and organ damage. This is also correct. Now, the wrong option here is answer B, because always we have read that thromboxane A2 level is increased and prostacyclin levels are down. Okay. So, in this reverse is given. So, in cases of preeclampsia or PIH, thromboxane A2 levels is increased and prostacyclin levels are down. So, the net effect is vasoconstriction. Next question. A woman who has taken tamoxifen following the breast cancer treatment for 5 years now wants to conceive. How many days after stopping the tamoxifen she can conceive? So this is a very, very straightforward answer. Answer is 3 months. Now, next question. 37-year-old woman is unmarried and she is on OCPs. She is sexually active. She visits her gynecologist for routine screening. Her mother had breast cancer at 55 and her sister had ovarian cancer at 40. What would you advise? So it is breast ovarian cancer syndrome, that there is a strong family history of breast cancer in the mother and the ovarian cancer in the sister. So she should stop OCPs. Prophylactic surgery she should get it done, that is bilateral salpingo-oophorectomy. Mammograms every year. But what about the screening for ovarian? Now, genetic testing and BRCA gene testing. So correct answer is BRCA1 and 2 gene testing. So this patients, if there is a history, family history or genetically predisposed, or she is carrying BRCA1 and BRCA2 gene mutation, then there is a risk for breast and ovarian cancer. So she should go for a genetic testing and BRCA1 gene testing. BRCA1 gene is located on chromosome number 17 and BRCA2 gene is located on chromosome number 13. So she should go for a genetic testing. Now next is, as per WHO SAGE guidelines, the recommended dose for HPV vaccine in 19 to 14 years of age group girls is 1 to 2 doses. The recommendation for HPV vaccine is 9 to 26 years, this is WHO guidelines. Okay, the ideal or the best age for vaccination is 11 to 12 years of age, because immune response to an antigen is very good at this particular age group. Hence, it is very, very important to vaccinate the girls at this particular age group. So the dosage schedule 9 to 14 years is 0 and 6 months, and dosage schedule for HPV vaccine between 15 to 26 years is 0, 2 and 6 months. And the vaccine is a Gardasil vaccine, which is a quadrivalent vaccine against HPV 6, 11, 16 and 18. Okay, so that is Gardasil vaccine. Nowadays, there is Gardasil 9 is also available, which is a nonavalent vaccine. This is against HPV 6, 11, 16, 18, 31, 33, 45, 52 and 58, and dosage schedule is 0, 2 and 6 months intramuscular. Fine. Now, next question is, a female presented with vaginal discharge that is non-itchy, acidic pH, yellowish, discoloration, lactobacillus counts are normal. What is a likely diagnosis? So it cannot be chlamydia. Chlamydia usually do not cause vaginal discharge. It is a cause for cervicitis. Now, bacterial vaginosis. In bacterial vaginosis, like the lactobacillus counts are reduced because it has been replaced by Gardnerella vaginalis. And one more thing, there is a clue says there is fishy odor vaginal discharge and the pH is more than 4.5. So this is also not fitting into this question. Now, Candida usually has an itchy or pruritus kind of vaginal discharge, and it is thick curdy white vaginal discharge. So in Candida, there is thick curdy white vaginal discharge and itching is present. So again, this does not fit. So it is excessive normal discharge, which is called as leukorrhea. Okay. Next, a pregnant lady with known history of fibroid uterus presents with acute pain, abdomen, fever and increased leukocytosis. So she is a pregnant female with a fibroid uterus. Now she has acute pain abdomen. If it is a pregnancy with acute pain abdomen, my first differential diagnosis would have been abruptio placentae. But here fibroid is written, so we will think in terms of fibroid. So there is an acute pain abdomen, fever and increased TLC. So this is red degeneration of the fibroid. This is clear-cut question. Next, a 26-year-old female came with a history of infertility for 6 years. BMI is 30 kg per meter square with excessive facial hair. So there is a history of infertility. There is history of overweight or obesity, and there is history of hirsutism. So this is PCOS, polycystic ovarian syndrome. So I would advise the lifestyle modification, that is weight reduction, metformin, ovulation induction with clomiphene citrate, because in the question there is history written as infertility. Let us read other options as well. Weight reduction, metformin, ovulation induction with urine gonadotropins. Gonadotropins is never as a first choice when it comes to the ovulation induction in PCOS patient. It is either letrozole or clomiphene citrate. So this does not fit in the answer. Finasteride, metformin. Finasteride is not an ovulation induction agent. We don't recommend a spontaneous conception in cases of PCOS because there is an ovulation. So we have to give ovulation induction agents. Now, fourth option is finasteride, metformin and ovulation induction. Finasteride has nothing to do. It will correct the hirsutism, but we do not want to give this because lady is planning to conceive. So first step would be weight reduction, lifestyle modification, metformin to reduce the insulin resistance, and that will automatically correct the ovarian cycle. ovulation induction with clomiphene citrate. Next question in this series is most common cause for menorrhagia in puberty. Is it anovulation, endometriosis, malignancy, or bleeding disorders? Okay, so they are asking about pubertal menorrhagia, and pubertal menorrhagia, the cycles are anovulatory because the hypothalamo-pituitary ovarian axis is just in the process of maturing. So usually the cycles in the beginning of puberty are anovulatory. There is high levels of estrogen and lack of progesterone, and ovulation does not occur. That is what is anovulatory cycles. Now, next question is, a female presented to Gynae OPD with complaints of vaginal discharge. Upon further investigation, clue cells were found in microscopy. What are these clue cells? Gardnerella vaginalis rods accumulated, epithelial cells studded with bacteria, macrophages which have phagocytosed dauberline bacilli, or none of these. So answer is epithelial cells studded with bacteria. So these are what are significant clue cells for bacterial vaginosis. A lot many questions in INI-CET exam has been asked on bacterial vaginosis, and all of these questions I have added up in these series. Now, next question is, which of the following is not the treatment for endometriosis? Again, endometriosis is very commonly asked question in INI-CET exam. So, let us read the options. Estradiol, cabergoline, leuprolide, and MPA, that is medroxyprogesterone acetate. Medroxyprogesterone acetate is been given to treat the features of menorrhagia. So, this is given. Leuprolide acts as a GnRH analog. So, this is also recommended in endometriosis. Estradiol has got no role and cabergoline has got no role. So, the answer is A and B both. Next question, SRY gene is located on. SRY gene is called as sex determining region on Y chromosome. So, it is present on the distal end of short arm of Y chromosome. So, the correct answer is short arm of Y chromosome. Next question, complete gonadal agenesis in males is due to SRY gene mutation. This is point mutation. So, options given was deletion, inversion, point mutation, or translocation. So, the correct answer is point mutation. Now, next is, which of the following will require evaluation for primary amenorrhea? Absence of menses by the age of 15 years. This is correct. No menses within 3 years of taiyaar, that is breast development. This is also correct. High TSH with short stature. This also requires evaluation. Absence of taiyaar by 13 years. So, answer is all of the above. Now, primary amenorrhea. What is the definition? Primary amenorrhea, we say by 15 years or by 13 years. By 13 years of age, if taiyaar, pubarchy or menarche are absent, this is primary amenorrhea we should evaluate. Or by 15 years of age, taiyaar has occurred, pubarchy has occurred, that is axillary pubic hair development has taken place, but there is no menses, then also we call it as primary amenorrhea and we should evaluate. So, all of the above are correct in this question. Next, which one is incorrect or which is wrong? Cystocele, colposuspension, uterine prolapse, vaginal hysterectomy, rectocele, posterior colporrhaphy, and vault prolapse sacrospinous suspension. So, vault prolapse sacrospinous suspension, this is correct because in this case, after the hysterectomy, that vaginal vault, there is a stitch taken and using a stitch from the sacrospinous ligament, it is tied posteriorly. So sacrospinous ligament is a strong ligament. So vaginal vault sacrospinous suspension is correct. Rectocele posterior colpo. Actually, the term is posterior colpo perineo raphe. So nearly this is also correct. Uterine prolapse vaginal hysterectomy. Okay. Cystocele. Cystocele, the surgery is anterior colpo raphe. So colpo suspension term is not used for cystocele repair. Now one question you should know, which is the most common type of genital prolapse? So the answer is cystocele, that is bladder prolapse in the vagina. That is the most common type of genital prolapse, and the surgery for this is anterior colpo raphe. Next question. A female presented with complaints of dysmenorrhea, dyspareunia, that is painful menstruation, dyspareunia, that is painful coitus, painful menstruation, dyspareunia is painful coitus. On examination, uterus is retroverted, tenderness in pouch of Douglas. So this history, clear cut, makes a diagnosis of endometriosis. Okay, what is your next step in management for endometriosis? What do you think? We should go for a gold standard investigation, that is a diagnostic laparoscopy, where we can see three types of endometriosis. One is a chocolate cyst of ovary. Number 2, peritubal or periovarian adhesions. And number 3, scattered endometriotic implants. Okay, so all these three types of endometriosis we can diagnose with laparoscopy, and wherever possible we can do. If the chocolate cysts are big and it is presented with adnexal masses, we can do fulguration and damage to the cyst wall. Or if the size of the cyst is more than 3 to 4 centimeters, then we can do the ovarian cystectomy. For the peritubal and periovarian adhesions, using the laser or the cautery, we can do adhesiolysis. And for endometriotic implants, we can burn the endometriotic implants, because this is a cause of chronic pelvic pain or congestive dysmenorrhea. Now, next question. Which is responsible for fetal heart rate? Autonomic function of the brainstem, humoral factors like ANP, carotid baroreceptors, or aortic baroreceptors. So always whenever we used to read this topic of the antepartum or intrapartum fetal surveillance, for checking the fetal heart rate in the physiology or in the final year MBBS exam, we have always been taught that it is the autonomic function of the brainstem which is responsible for this. So there is an interaction of the autonomic system relation with the fetal heart rate. So biophysical profile or Manning score is based, like fetal biophysical activities are initiated, modulated and regulated by fetal nervous system. If there is a hypoxia, there is metabolic acidosis, there is CNS depression. So that changes the fetal biophysical activity. Deceleration occurs when it is usually fetal heart rate is being controlled by the autonomic and somatic nervous system. So in responses to hypoxic stress, there is a reduction in the fetal heart rate, and this is a way to preserve the myocardial oxygenation and perfusion. Unlike in adult, the fetus cannot increase the respiratory depth or rate, so there is reduction in the fetal heart rate to save the oxygenation supply to the myocardium. So myocardial demand is referred as the deceleration. So it is the interaction between the autonomic and the somatic nervous system. Now, all of the following are the causes of non-immune hydrops fetalis except. So ABO incompatibility is the cause for immune hydrops fetalis. Otherwise, In the immune hydrops fetalis, it is Rh incompatibility, which is more common cause for immune hydrops fetalis because antibodies are formed in the mother against the fetal Rh positive RBCs and they cause destruction leading to hemolytic anemia. So baby is born with pleural effusion, pericardial effusion, generalized anasarca. There is ascites, that is what is a hydrops fetalis. Now, parvovirus B19 thalassemia, that is alpha thalassemia, and the sickle cell anemia. These are the causes for non-immune hydrops fetalis. Okay. Now, in the causes category, fetal causes, if I talk about the fetal causes for non-immune hydrops fetalis, it is the hematological causes like hemoglobinopathies, which is alpha thalassemia. Then there can be, decreased erythrocyte production, myeloproliferative disorders, feto-maternal hemorrhage. Then there can be cardiovascular causes, which can be abstain anomaly or Fallett's tetralogy, or there can be absent pulmonary valve, or there can be hypoplastic left or right heart, etc. There can be cardiomyopathies, tachyarrhythmias. There can be infections like, present question is based on the infections like TORCH group of infections where parvovirus, syphilis, cytomegalovirus, toxoplasma, etc. All these are the causes for non-immune hydrops fetalis, that is infection which is leading to the infection of the bone marrow, leading to bone marrow suppression and leading to aplastic anemia, which can cause non-immune hydrops fetalis. So you can just go through the causes. Now next question is, which has least perinatal transmission? So herpes simplex virus, cytomegalovirus, rubella, and hepatitis B. Cytomegalovirus is the most common cause for congenital infection. Herpes simplex virus type 2, it is transmitted to the baby at the time of delivery. So it is very important cause for perinatal transmission. Hepatitis B is also transmitted if the vaginal delivery is allowed. Okay. Now, answer to this question is rubella. Usually, rubella infection is more common in first trimester. So, usually less than 12 weeks of pregnancy, the maximum transmission of rubella occurs from mother to the baby. So, IgM antibodies, if increased in the first trimester, then the baby is at risk of congenital anomalies and MTP has to be done. So, least perinatal transmission is seen in rubella. So, MTP is recommended because of the risk of congenital rubella syndrome. Now, what is a type of congenital heart disease in congenital rubella syndrome? Answer is PDA, patent ductus arteriosus. Now, next, 32-year-old women visits to OPD with history of painless ulcer on the vulva. Her obstetric history reveals that there is a history of stillbirth at 28 weeks. She has got contact with multiple sexual partners. So, they are talking about STD. Okay, lupus, anticoagulant, and none of the above have been ruled out. So, the options are VDRL testing or HIV testing. Now, painless ulcer goes in favor of syphilis. Okay, and there is history of multiple sexual partners. So, there is history of promiscuity. Okay, and there is history of stillbirth at 28 weeks. Okay, so painless ulcer, history of promiscuity, stillbirth in the previous pregnancy at 28 weeks. This all goes in favor of syphilis infection. So, provisional diagnosis is syphilis. For that, testing has to be done in the form of VDRL testing. That is a cost effective, and there is a routine testing in all pregnant ladies in our country because there is a risk of congenital syphilis that can occur. And if the pregnant lady has been diagnosed with syphilis, then we have to offer the treatment to reduce the chance for transmission to the baby. So that's all from this series. Thank you. I hope this session is going to be useful to you for your upcoming exam of INI-CET. Thank you and all the best.